Hello viewers, I am Dr. Roviul. I am an assistant professor of pathology in a medical college hospital and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is on thalassemia. This is the first lecture of our thalassemia lecture series, and in this lecture we will learn what do we mean by thalassemia, how does this disorder develop, what are the types of thalassemia, and then we will mainly focus on beta thalassemia and talk about the clinical features, lab diagnosis and treatment of beta thalassemia. Then in the next lecture we will talk about alpha thalassemia and finish our discussion. Okay, a lot of topics, so let's begin. First question, what do we mean by thalassemia? Now the first thing that we have to remember is thalassemia is a genetic disorder, and as we will see, the mechanism, the underlying genetic mechanism of this disorder is not very simple. It is diverse. That's why it is written in your textbook that it is a genetically heterogeneous disorder. That means it is a genetic disorder that has diverse mechanism, but as we will see, the outcome leads to thalassemia. So what is happening in this genetic disorder? There is reduced synthesis or reduced production, or there may be absence of synthesis or absence of production of one or rarely more than one type of globin chains in the hemoglobin, and that will lead to anemia, hypoxia, that is lack of oxygen in the tissue, and red cell destruction or red cell hemolysis, as we will see. So how can we define thalassemia? Let's just summarize what we have just mentioned. Thalassemia is a group of disorder, and it is a genetically heterogeneous group of disorder characterized by reduced synthesis or absent synthesis of usually one or rarely more than one type of globin chains, and this leads to anemia, tissue hypoxia, and red cell hemolysis or red cell destruction. So now let's explain this definition. Now, in order to understand the definition, we have to pause our lecture here and focus a few words about hemoglobin's synthesis and hemoglobin's structure. Now, we all know that hemoglobins are specialized iron-containing proteins, and they are present in the cytoplasm of red blood cells. Their main function is to carry oxygen. Now, often I tell my students to think of hemoglobin like a pickup truck and oxygen as its payload. So, the red blood cells, when they're flowing through the vessels in the lungs, they are collecting oxygen inside the hemoglobin, just like a pickup truck is taking its payload. And when those same red blood cells are going to the tissue, they are releasing oxygen, just like a pickup truck unloads its payload. Okay, so hemoglobin is very important because with the help of hemoglobin, oxygen is carried from the lungs to the tissue where it is needed for various works to be done. Now, hemoglobin, how hemoglobin is produced, that is very important. And as you can see, I have drawn a cell here. Now, one thing you have to remember, hemoglobin is produced in the precursors of red blood cells in the bone marrow. In those precursor cells in the bone marrow, we will see inside the mitochondria there is condensation of glycine with succinyl coenzyme A. I missed this, succinyl coenzyme A. And in this reaction, vitamin B6 acts as a coenzyme. So what is happening? Glycine and succinyl coenzyme A, they are condensing to form delta aminolevulinic acid. Then this structure is leaving the mitochondria and entering into the cytoplasm of those developing precursor cells in the bone marrow. They are forming porphobilinogen, uroporphyrinogen, coproporphyrinogen. Ultimately, they are again coming back into the mitochondria from the cytoplasm, and we can see protoporphyrin. This is very important for your multiple choice questions. So ultimately what is happening, at the same time we can see that iron has entered in the cell, and ultimately protoporphyrin and iron, they are combining to form heme. This is the heme portion of the hemoglobin. And from where are we getting the globin? Globin chains are produced in the ribosome. And always remember that there are several types of globin chain. The most common includes alpha and beta. The normal adult hemoglobin, which is also referred to as hemoglobin A, that contains 2 alpha and 2 beta globin chain. Similarly, the hemoglobin that we see in fetal life, that is known as hemoglobin F, that hemoglobin contains 2 alpha and 2 gamma chain. And hemoglobin A2, that is another hemoglobin that we have in a very small percentage in adult life, that contains 2 alpha and 2 delta chain. So the point I'm trying to make here is hemoglobin is very important. Hemoglobin contains heme and globin chains are in tetramer, that is 4 in number, and they are in 2 pairs. In thalassemia, usually one type of globin chain is reduced or sometimes totally absent. As a result, we will have less and less hemoglobin produced, and that will lead to anemia. Recall from my first lecture of anemia, we know that anemia is a condition where the hemoglobin level is less than the lower normal limit. So since in thalassemia we are producing less and less globin chain of one particular type, so we cannot produce sufficient amount of hemoglobin, and that is leading to anemia. So that's why we can say in the definition it leads to anemia. And we also know that hemoglobins are responsible for carrying oxygen. So now there is reduced amount of hemoglobin, so less oxygen is carried to the tissue, and that results in tissue hypoxia. Now the last point that we have said in the definition, red cell hemolysis. Why is this thing happening in thalassemia? This is very interesting. I have already mentioned in thalassemia, one type of globin chain is reduced or sometimes absent. For example, if we are talking about hemoglobin A, we have 2 alpha and 2 beta globin chains in hemoglobin A. Now let's suppose that in that person beta chains are not produced. So there will be excess alpha chains that cannot bind with beta chain. So what will happen to those unbound alpha chains? They will precipitate, and that will cause membrane damage in those developing red blood cells, and ultimately those cells will become destroyed, and that will lead to destruction of those precursor cells. So this was in short about the explanation of the definition of thalassemia, and I think we are now getting an idea. So now that we have talked about the definition of thalassemia and hemoglobin structure and hemoglobin synthesis, now let's classify thalassemia, and we will talk about the common types. Always remember, when there is reduced synthesis or absence of synthesis of beta globin chain, that leads to beta thalassemia, and when there is reduced synthesis or absence of synthesis of alpha globin chain, that leads to alpha thalassemia. Now, beta thalassemia can be clinically classified into Beta-Thalassemia Major, Beta-Thalassemia Intermedia, and Beta-Thalassemia Minor. Similarly, alpha thalassemia can be clinically classified into silent carrier, alpha thalassemia trait, hemoglobin H disease, and hydrops fetalis. So we will talk about alpha thalassemia in our next lecture. So for today's lecture, let's focus on beta thalassemia. So first, let's talk about beta thalassemia major. In beta thalassemia major, there is severe anemia and it requires repeated blood transfusion. Hemoglobin level is usually from 3 to 6 gram per deciliter in untransfused patient. Beta thalassemia major, the clinical features are usually presented from 6 to 9 months when there is a shift from hemoglobin F to hemoglobin A in the red blood cell. So it is usually expressed 6 to 9 months after birth because that is the time when our red blood cells are shifting from hemoglobin F to hemoglobin A, and hemoglobin A contains beta globin. Now, beta thalassemia major is common in Mediterranean countries, in parts of Africa and Southeast Asia. And as we will see, in beta thalassemia major, the main hemoglobin will be hemoglobin F. Sometimes hemoglobin A2 is slightly raised, but more often hemoglobin A2 is normal or low. Now, what is the genotype of beta thalassemia major? In order to understand the genotype, we have to know about the gene that is responsible for making beta globin chain. Always remember, the gene responsible for making beta globin chain is located in chromosome number 11, and each chromosome number 11 has one gene that makes the beta globin chain. So we have one gene that makes beta globin chain in the chromosome number 11 that came from our father, and we also have another gene that makes beta globin chain in the chromosome number 11 that came from our mother. And here the normal gene is denoted as beta. Now always remember, in beta thalassemia, the most common genotype is happening due to gene mutations, okay? And hundreds of mutations have been discovered, so we won't go into the detail of those mutations, but usually those mutations fall under three categories. So there may be splicing mutation, there may be mutation in the promoter region, or there may be mutation that results in chain termination and formation of stop codon or formation of frame shift mutation. So we will keep it there. Just remember that the normal gene that makes beta globin chain is denoted as beta, and there may be mutation in that gene, and these mutations can be categorized again under two broad headings. One is beta 0 and one is beta plus mutation. In beta 0 mutation, absolutely no beta globin chains are produced. There is complete absence of beta globin chain. And in beta plus mutation, we will see that some beta globin chains are produced. And in thalassemia major, there will be homozygous thalassemia. For example, you can see here both are beta 0. Here in this we can see both are beta plus mutation, and in this option we can see one is beta 0 and one is beta plus, but no normal beta gene is seen here. So since both are mutated, so it is homozygous mutation. Okay, so always remember that in thalassemia major we have homozygous mutation. On the other hand, when we are talking about beta thalassemia minor, there we will have heterozygous thalassemia. That means we will see that one beta globin gene is normal and the other one is mutated. Either the mutation is beta 0 or the mutation may be beta plus. So always remember, beta-thalassemia minor genotypically will be heterozygous thalassemia. Now, in between beta-thalassemia major and beta-thalassemia minor, we will have thalassemia intermedia, and there the genotype will be variable, and I will show you the genotypes on screen. But always remember, in beta-thalassemia intermedia, there may be other problems. For example, there may be alpha thalassemia as well, or there may be excessive production of alpha globin chain due to gene duplication, and these things will complicate the matter, and that's why the genotype will be variable, and so will be the outcome in case of beta-thalassemia intermedia. So what will be the clinical features of a patient with beta-thalassemia? We have already mentioned that if the patient has beta-thalassemia major, the patient will suffer from severe anemia that will require repeated blood transfusion. The hemoglobin level will be from 3 to 6 gram per deciliter in case of untransfused patient. Now, if we are talking about beta-thalassemia minor, these patients will be asymptomatic or they may be mildly anemic. And just like the genotype, the clinical features of beta-thalassemia intermedia are also quite different. They will also suffer from severe anemia. However, they will not require repeated blood transfusion all the time. So one thing you have to remember, that particularly in case of beta-thalassemia major, the patients may have prominent cheekbone, and that is very interesting because why is that thing happening? In beta-thalassemia major, there is very low amount of beta globin chain in the red blood cells, and that's why there is severe anemia. To counter this severe anemia, the bone marrow is trying hard to make excess red blood cells. Okay, so there is erythroid hyperplasia in the bone marrow, there is expansion of the bone marrow, and sometimes the bone marrow is expanding, and that is creating those prominent cheekbone. And also in the skull, the bone marrow expansion may be so rapid that may result in crack in the skull bone, and that will appear as hair on end appearance or crew cut appearance if we do an X-ray of the skull bone. So always keep that in your mind, that in beta-thalassemia major, there is expansion of the bone marrow to counter the severe anemia, and when doing so, that may result in prominent cheekbone, that may result in hair on end appearance or crew cut appearance in the X-ray of the skull bone. Now, one thing you have to remember, particularly for beta-thalassemia major, that in beta-thalassemia major, there will be ineffective erythropoiesis. Now, what do we mean by that? The thing is, the red cell precursors in the bone marrow in beta-thalassemia major, they have excess amount of alpha globin chains that are not bound with beta because there is reduced amount of beta or absence of beta chain. So those unbound alpha chains will precipitate, that will damage the membrane of those red cell precursors, and many of them will die by apoptosis in the bone marrow before leaving the bone marrow. That is known as ineffective erythropoiesis. The remaining precursor cells that do leave the bone marrow, they are still defective, right? Because they contain those alpha globin chains as precipitate. So those cells will also die in the spleen, and spleen will have a heavy workload, so that will also lead to enlargement of the spleen, that is known as splenomegaly. So that was in short about the clinical features of beta-thalassemia major, and in case of beta-thalassemia minor, the patients are asymptomatic or mildly anemic. So now let's move on and talk about the laboratory diagnosis of thalassemia, particularly beta-thalassemia. So in Beta-Thalassemia Major, we will see severe anemia. There will be microcytic, hypochromic red blood cells, right? So mean corpuscular volume will be reduced, mean corpuscular hemoglobin will be reduced, reticulocyte count will be increased, but not according to the severity of the anemia, because a lot of the cells are getting destroyed in the bone marrow due to ineffective erythropoiesis. Now, one thing we have to remember that in Beta-Thalassemia Major, we will see target cells, plenty of target cells in the peripheral blood film. Now, what is target cell? Target cells are a type of red blood cells. Normally, red blood cells are biconcave circular disc-shaped structure. So this is a red blood cell, a normal red blood cell viewed from the top. This is the same red blood cell viewed from the side. And you can see that the central area, the concave area, contains less hemoglobin, and that is pale in color, and usually 1/3 is pale. But when we're talking about Beta-Thalassemia Major, because there is lack of hemoglobin or very low amount of hemoglobin in the red blood cell, so the red blood cell begins to fold. Okay, so there may be additional folding in the center where normally there was concavity, and that creates a structure like this, and hemoglobin also gets accumulate in those foldings. And if we view that from top, we will see like this bullseye appearance that is known as target cell. Okay, so in Beta-Thalassemia Major, we will see plenty of these target cells, and that is happening due to accumulation of hemoglobin in a fold that is created due to lack of hemoglobin. It's like a football, you know, when there is less air in the football, the ball crumbles, there is folding seen. Similarly, when there is less hemoglobin, the red blood cells are folding in the center and creating additional area where hemoglobin can be accumulated, and that is resulting in formation of target cell. Now, one additional finding that we will see in the peripheral blood film of Beta-Thalassemia Major is presence of nucleated red blood cells. Actually, those are precursor red blood cells. And why will we see them? That is happening because bone marrow is getting frustrated, and ultimately it is sending whatever it has in the blood so that some hemoglobin can be used. Okay, so that's why we will see that nucleated red blood cells are now seen in the peripheral blood film. That is indicating stress in the bone marrow. The bone marrow is overstressed, and in order to deal with the hypoxia, it is sending whatever red cell it has or red cell precursor it has so that some amount of oxygen can be carried. Okay, so always remember that in Beta-Thalassemia Major, we will also see nucleated RBC or NRBC in the peripheral blood, and also there will be plenty of target cells. So how can we confirm the diagnosis of thalassemia? Always remember the answer is hemoglobin electrophoresis. This is a very important question that you will be asked, and I will also show you the hemoglobin electrophoresis findings of different types of thalassemia on the screen. So what are the complications of this Beta-Thalassemia Major? Now, if we don't transfuse the patient has a very high chance of dying. Okay, and if we provide sufficient transfusion, the patient can survive well into third decade, and more better treatments are now coming. For example, stem cell transplantation can provide cure from this disorder. Now, one thing you have to remember, I have already said that patients of Beta-Thalassemia Major, they require repeated blood transfusion, but that also has a complication. Always remember that when we're doing repeated blood transfusion, that can result in iron overload. Okay, and that will result in a condition known as hemochromatosis, and iron will be deposited in certain organs like heart, liver, pancreas, and those organs will get damaged. In order to counter that, iron chelating agents are often used in patients of thalassemia. So, what are the treatment options? I've already mentioned that repeated blood transfusion, iron chelating agent, and stem cell transplant. These are the common treatment options available for thalassemia and beta thalassemia. So this concludes our first lecture on thalassemia, and in our next lecture we will talk about alpha thalassemia in detail and finish our discussion. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.